All right, back in Santa Monica with my favorite doc, Ask the Doc, Dr. Rand. How are you, my friend?
I'm great. Thanks for asking.
All right, we got some good questions this week.
Yep. You want me to start with them?
Yeah, man.
Okay. So this first one is from. Am I supposed to say the name?
It's okay. If they put the name, we're good.
Brandon Kretsch. Hey Doc, I know this video's older, but I was hoping to ask a question to you, or if someone in the comments section can answer this question, that'd be great. So I purchased HGH from the site I chose to go to about a year ago, and it's been in the fridge since it's still in powdered form. My question is, how long can the powder stay viable if it's unconstituted? I'm finding it very hard to get information on safe use of HGH. I just started my treatment for my back. I've taken it in the past for my degenerative disease and had great success. I'm only taking 2 IUs a day and then up to 4 over time. However, after one injection, I've got extreme stomach cramping, bloating, and my vision is kind of blurry. Now I have IBD and IBS, which is another reason I'm taking HGH. So I'm used to stomach cramping and bloating, but I've been very cautious with my food. I'm eating less sugar, if no sugar. And while I'm on the HGH, I'm limiting my carbohydrate intake to avoid insulin resistance. Any quick advice or thoughts would be appreciated. Also, just a quick note, the last time I took HGH 3 years ago, shortly after I was diagnosed with an enlarged spleen. Not sure if the HGH is the reason or if it was my rapid weight gain. Was depressed and put on 80 pounds in 1.5 years. Wow. But still something to consider. I love to talk to my doctor, but the last one I spoke to said, "What is GH?" And I laughed and walked out of the office. Laugh out loud. Okay. So, it's just, again, I can't give medical advice, guys. I mean, you know that. But hopefully I can be helpful with my answer here. First of all, with regard to the growth hormone really is technically not even a peptide because it's 191 amino acids, so I guess we would call it a protein. But that's semantics. If you cook it, we call it denaturing it, then yeah, it won't be viable anymore. But if you've kept it in the refrigerator, the only thing you would consider about that, I would think, would be not some sort of issue with it being bad for you. It would lose potency. So instead of being really 100% potent, it might be maybe 97. It depends upon the temperature which it's kept. Heating just breaks down the bonds between the amino acids, and then it's just not as effective. Again, it wouldn't be dangerous to use. In other words, it would just be maybe not as efficacious. So, and that's again if it's not reconstituted. Once it's been reconstituted, it's more likely to break down much faster. But in this case, perfectly safe for what he's asking here. And I don't think that his GH use, especially with 2 IUs a day, which would probably get IGF-1 levels up to maybe somewhere in the 200s. And even if you got up to 4, I mean, you might get up into the mid 300s or maybe a little higher. Depends on the person. But that and that's a level you might have been producing on your own when you were 20 years old. So that's a relatively safe dose in terms of exogenous use. Now that's taking into consideration nothing, meaning, have you been screened for cancer? It doesn't say what his age is. There's a lot of factors here, so I'm not giving medical advice. I'm just saying in very, very general terms here. That's a relatively low dose. Most of the studies that they most of the studies they perform, they use somewhere between roughly 1.8 IU on up to typically no more than 2 point something IU for what we might refer to as anti-aging purposes or regenerative medicine purposes. It's more of a replacement dose, even though, as I just said, it would not necessarily put you at a super physiologic dose if you used 4 IUs. Everyone's different, but you might be up around, again, what you were producing when you were a teenager. But it would certainly be super physiologic, the assumption being if you're 40, because you're not a teenager anymore. But anyway, in terms of the side effects, growth hormone, and I won't go too far afield, I promise, when I say that, GH belly and I don't know if I've said this before, but I think it has mainly one cause, and that's just, feces, if you will, bowel contents slowing. And so it's backed up in there, and that might exacerbate irritable bowel disease or irritable bowel syndrome simply because the migratory motor complex is slowing, and therefore you've just got more stuff in your intestines, right? And that is one of the side effects of growth hormone. It makes sense if you think about it, because as you're growing up and your growth hormone levels are high, you're trying to get as many nutrients as possible. You don't want this stuff to pass right through you. If you think in terms of evolution, I mean, we weren't going to any grocery stores 100 years ago, or certainly 300 years ago, even 1,000 years ago. 1,000 years ago, which is a blink in evolutionary terms, but it makes sense, in other words, to slow this so we can get as much out of it as possible. So that might be causing some of the cramping and bloating. In terms of the blurry vision, we know that, and I think he might be trying to address it here, that growth hormone will affect your sugars. Typically, it raises blood sugars a bit, so that you might see maybe if you're looking at hemoglobin A1C, which is a measurement of sort of an average sugars over 3 to 4 months, you might see like a 0.3% on your average person increase in that. So your sugars go up a little bit, and that could affect your vision. And of course, the opposite could be true, where the sugars go up temporarily, and then your insulin comes in and opposes it and drops your sugars. But that might be the blurry vision, or it could be something completely unrelated. But in terms of tying it to the growth hormone, that might be the issue, just blood sugar. But you might want to look into that, certainly, because it's not normal to have blurry vision. That's not just because, that comes and goes. It's not just because you need new glasses or something. In terms of limiting carbohydrate intake, I think that's what he's referring to, but I don't want to go too far afield here, but you don't necessarily have to curb your carbohydrate intake while on GH. A lot of people talk about that so they don't get a bloat, so they don't get insulin spikes and all kinds of rationales, which would really open up a big Pandora's box if we go into it. But a lot of people do very well eating, and we were just kind of touching on this at lunch, eating plenty of carbs, with or without growth hormone. So that would be an individual thing. And then the enlarged spleen, I can't imagine why that would have anything to do with growth hormone. I would look into that as an entirely different issue, something to do with, red blood cells, or again, I don't know what's going on there, but I would definitely see a doctor about that if you haven't already. And the rapid weight gain, I mean, okay, stretching out over 1.5 years, I guess that's doable. Do you know anybody who's put on 80 pounds in 1.5 years?
That's a lot.
That's a lot of weight. And I would say, even if it were muscle, maybe even more so if it were muscle, which would be unbelievable.
Yeah.
And you have to start really light to begin with, and you probably have to be a pretty tall gentleman, etc. But that would be pretty hard on the cardiovascular system, I would guess. So I guess what I'm saying here is, check into your general health to be able to put on that much weight and be healthy still. Make sure your cardiovascular system is commensurate, in terms of function with that much mass. Again, whether it's fat, hopefully not fat, hopefully it's mainly muscle. And then I can only laugh with you about the doctor. How could a doctor not know about that? I don't know where you are or who you're seeing, but go see somebody else and get some good. No, but seriously, get some medical advice. Again, I don't know where you are, but there are places where, obviously, where human growth hormone. If this gentleman's in Canada, for example, doctors should know about it, and they prescribe it more generously than certainly we do here, which is very, very, very tightly regulated, and only for certain very rare circumstances. So, anyway. Hope that helps.
Thanks, Doc.
Yeah. So this one is from David Coombs, and he says, so, hypothetically speaking, if one was to have accidentally taken 3 cc's a week for a month of tescipinate, looks like, 250 milligrams per ml, what should they do next? Like, say they're not a doctor and they stupidly thought 3 cc's meant 300 milliliters, or maybe you meant milligrams. Anyway, what would you recommend? Okay, let me think about this for a second. First of all, well, let me start with we have at least one study, and I'd have to look it up. I don't remember where I saw it, but it was a long time ago, where 600 milligrams of testosterone in a esterified form, I think it was testosterone cypionate, was used. And I don't remember the markers they used to determine health and whatnot, but the upshot of the study was that the individuals, and these were all males, were actually in pretty good health, actually better health with more than the typical dose, which is roughly 200 milligrams per week, with most of the guys that are doing TRT these days. So 3 times the standard dose, we'll call it, as long as their estrogen was controlled, as long as their hemoglobin and hematocrit as well as the lipids weren't too adversely affected. You're not going to read many studies like that, at least in English. But the point being, I guess, that I wouldn't hit the panic button. What's done is done, and I don't even know if there's an LD50 for if there's a lethal dose determined for testosterone. But that's certainly not lethal, and I imagine just watch out for side effects. Manage the estrogen, because this is going to take a while when you get to that high a dose to bring it back down to a more optimal dose. But you want to make sure the estrogen's under control. And I'm being very general here, and without getting too far afield. Again, it depends on what other issues you might have, comorbidities, and what other general health you're in. But if you're in really good health and you don't have any comorbidities, then just stop for a while. Consider taking some assays of your testosterone until it drops to a more optimal level before you start with therapy again. And you really don't have to do anything else at this point, unless I'm not reading clearly what the question is.
No, I think that's it. I think he just took more than what he should by mistake.
Honestly, that's one of the beauties of TRT, and one of the reasons I can sleep so well at night is because even if something like this happens, because a lot of people are self-applying this, and they can make mistakes like this. You're not killing anybody, and the side effects are typically excess water retention, and it could be excess fat retention. Although, how long are you going to go before this gets caught? You're going to get a refill request. It doesn't make sense. You go, oh, what's going on here?
Yeah.
So, the water retention, nipple sensitivity, gynecomastia, things that are all related to the production of excess estrogen is typically what we'd see. Don't really, over the long term, which is not part of the question, but just to ramble on here, I guess, is, you're going to see when you get to a supraphysiologic dose of testosterone, unlike with a common TRT dose of just 200 milligrams a week of an esterified form like testosterone cypionate or enanthate, you're not going to see an elevation in hemoglobin, red blood cells, and of course hematocrit along with, just because you started testosterone. Okay, it's typically, I think we've talked about this before, the testosterone leveraging, say, sleep apnea, where there's a strain on the body and the body's reacting to it by creating more oxygen carrying capacity. But when you get up to doses like this, it is a concern just because of the testosterone at such a high dose, meaning the excess red blood cell production and hemoglobin production, which, based on the gentleman who was just here a minute ago, who I don't know if you overheard just even a little bit of that because we were in the hallway, but there's a lot of misinformation out there about the concerns over having elevations in red blood cell count, hemoglobin, and hematocrit, because there's a big difference between blood viscosity, thickness, and blood stickiness, its ability to coagulate, right, and form a clot. Now, there is a connection at some point up the road there. If it's so viscous that its movement throughout the body gets slow, well, then it's more easily coagulated. It's more, the cells can stick together more easily. That's why atrial fibrillation can be such a problem, because the heart's inefficient at pushing it through the heart, and so you can have these little eddies that form, and blood can stick together. But still, there's a big difference between the two, okay? And so to have, say, a hemoglobin of 17.5 is not going to put you at some great risk of clot formation. I have a patient who has polycythemia rheumatoid vera, an autoimmune disorder, and I've seen him in here with a hemoglobin of 23.5 and like I want to say hematocrit of something around 23. Sorry, 73. Excuse me, 73, which doesn't make sense because it's usually about a threefold difference. But anyway, he's I think he's still working. He's a very healthy plumber and does his job every day and doesn't faint or have any issues related to it. And the point being that these numbers can go relatively high, and you don't have the risk of stroke like a lot of people think. I'm not saying you don't have to consider these things. Don't get me wrong, but the perception's a little bit off. The main point I want to drive home is that you could see some elevations, and not in this gentleman. It's too short a period. Again, this would be picked up unless he's doing it on the black market or something like that, and he's not testing, and asking for refills of prescriptions every 10 weeks or something like that. So, but just to make the point that there is a big difference between viscosity and stickiness. That's all.
All right, thanks, Doc.
Looks like this gentleman's name is Egon Spinader. I'm probably butchering that, sorry. I really enjoy your videos. I'm writing from British Columbia, Canada, with respect to peptides, especially BPC 157 and TB 500. I have AFib, so I'm given Eliquis, which is a blood thinner. Have you heard anything that would disallow the use of peptides for people on blood thinners? May I also ask regarding TRT, do blood thinners somehow compromise the efficacy of either of these drugs? Interesting. I just kind of delved into this a little bit before this question, sorry, and I won't repeat a lot, I hope. But first of all, with regard to peptides, BPC 157, there's not a whole bunch of human studies. I think we might have touched on this before, but this peptide is produced in the body, in the GI tract, and we found that it's useful to help heal ligaments and tendons. TB 500, on the other hand, variation on thymosin beta 4, helps the body. It leverages the production of actin within the muscle fibers. And I find that it's helpful in general for the sarcomeres, but also I find it more helpful for us, I would say, masters athletes that might need a little more help with muscle accretion than, say, a 20-year-old, where I would say, for example, the juice isn't worth the squeeze, I would say, for someone who's 20 to use a peptide like that. And then is it, I think the question he's asking is it going to increase his risk of forming a clot? I don't want to answer out of turn, but I have I haven't seen anything that would suggest by the mechanisms of action alone why there would be any increased blood stickiness like we were talking about before. And neither of these drugs would affect the viscosity either, for that matter. But if someone's on Eliquis, which is a very powerful blood thinner, as they call it, something that would make the blood less sticky, there wouldn't be any concern, I wouldn't think, anyway. But of course, I would ask your physician in Canada, if you decide you want to use either of those peptides or any peptide, if that would be contraindicated. But again, I don't see any reason, just based upon the mechanisms by which they work, why we would do so. And then, may I also ask regarding TRT, do blood thinners somehow compromise the efficacy of either of these drugs? Okay, so so it's not regarding testosterone, but with regard to either of the peptides, I couldn't imagine why a blood thinner would actually make them less efficacious. Again, just based upon their mechanisms of action. But as I said earlier, we don't really have a whole bunch of studies, human studies, and I can't think of any of the mouse studies where we were using mice with AFib. So I really can't answer the question in a good way. And I'm sorry. Next time I'll see if I can do a little research beforehand and look it up. But I think I would have trouble finding it because, again, the research is so thin. I think I've seen most of the studies that are available, And I don't think we have an answer to that question yet, but I can't see why it would affect it negatively, meaning that they should still work effectively. And then ditto for TRT. Blood thinner should not affect testosterone replacement therapy at all.
Good to know. Thanks, Doc.